Good evening, everyone. My name is Jacob Koshi. I think we are waiting for Dr. Abhilasha. Thank you all for joining. Today
She will join now.
Yeah, today we will be having an interesting case discussion which might be useful for everyone attending here, faculty, students, everyone. And please feel free to stop and ask questions. Please feel free to clear your doubts. There are some very good faculty here who are willing to teach us, and let this be an enjoyable learning session. Thank you, KSOS, for organizing this, and I'm sure it's going to be an enjoyable evening. So, ma'am, shall we start?
I'll just invite Dr. Abhilasha on behalf of KSOS. Good evening, everyone. First, I invite Dr. Abhilasha. She's joining now. She's the lead consultant of New Retina Care, Hyderabad. I invite Dr. Jacob Koshi and Dr. Sadish Thomas and all the faculty of Believers Church Medical College, Tiruvalla, for agreeing to mentoring this session. Now I just hand over to Dr. Sandra. She's a resident in Believers Church Medical College. And she can start the PPT. You can share the presentation now. Okay. Dr. Abhilasha will join.
Visible?
Yeah, visible. Slides are visible.
Yeah, am I audible enough?
Yeah. Yes.
Okay. Good evening. Can I start?
Yes, you start.
Okay. Good evening, everyone. So today's case is about a 43-year-old female hailing from Dubai. She came to our OPD with chief complaint of decreased vision in her right eye since 3 weeks. 2 months prior presentation, she had menstrual irregularities and significant weight loss. And on evaluation from abroad, she found to have bilateral ovarian mass and underwent surgery for same. And biopsy showed necrotizing epithelioid granulomas. And thus, she was diagnosed as having abdominal tuberculosis and was started on ATT. So 3 weeks ago, she noticed decreased vision in her right eye. She found it difficult to read the numbers on the clock. It was painless and subacute in onset. It slowly progressed over 2 to 3 days and remained the same for 1 week. She had consulted a nearby hospital and they advised referral to a higher center to detail systemic evaluation in the scenario of worsening of symptoms while on ATT. She was evaluated under medicine department in our institute and was referred to us. She says improvement in her vision over last 1 week. Now she is able to read letters of both at a distance, although it is blurry. No history of floaters or flashes of light, redness, photophobia, or double vision. No history of any fever, headache, vomiting. No skin lesions or any hypopigmented patches, genital ulcers, or joint pain. No cough, breathing difficulty, recurrent infections, genital ulcers. No tinnitus or any hearing deficit. No history of contact with pets. And no specific complaints in other eye. Past history, she's a non-case of hypothyroidism and is on thyroxine 100 micrograms. No history of ocular trauma or ocular surgery in the past. Family history, no history of malignancy or any chronic ocular diseases in family. Personal history, sleep, appetite normal, bowel and bladder habits regular, no addictions, and no history of contact with TB patients. Drug history, she completed her intensive phase of 2 months and now is on isoniazid, rifampicin, and ethambutol. General physical examination, she's conscious and oriented, moderately built and nourished, no pallor icterus, cyanosis, clubbing, or generalized edema, no lymph node enlargement or any skin lesions or vitiligo, no alopecia, poliosis, no pitting of nails or oral ulcers, and her vitals were stable. On systemic examination, Central nervous system, no focal neurological deficit noted, and cranial nerve examination, no significant abnormality noted. Cardiovascular system, respiratory, GIT system were normal. In musculoskeletal system, no joint swelling were noted. Coming to ocular examination, her vision unaided in right eye was 6/9, not improving with pinhole. Near vision aided was N6 with a power of plus 1.5 diopters. Color vision was normal. Head posture, no abnormal head posture, orthophoric and no nystagmus. Ocular movements were both all dactions, versions, and versions were full. Eyelids, no nodules noted in eyelids. Conjunctiva, normal, no congestion. Sclera, no thinning, discoloration, or dilated episcleral vessels. Cornea was clear, no keratic precipitates. Anterior chamber depth was of Van Herk grade 4, no cells of flare. Iris normal in color and pattern, no nodule synecdoche. Pupil 2 millimeter round, sluggish direct and indirect reflexes, no RAPD. Lens clear, IOP, planation tonometry at 10 a.m. was 21. Gonioscopy, open angles, no peripheral anterior synecdoche. Lacrimal apparatus, no evidence of any swelling, tenderness of lacrimal sac and lacrimal gland regions. And regurgitation test was negative. In distant direct ophthalmoscopy, red glow was seen. On fundus examination, using 90 diopter lens, indirect ophthalmoscopy, media was clear. Disc margins was blurred circumferentially. No splinter hemorrhages noted. Vessels were arising from center of the disc, branching dichotomously, maintaining an AV ratio of 2:3. No tortuosity or sheathing of vessels noted. There was an elevated yellowish whitish round lesion with ill-defined borders of size 4×3 millimeters underneath the vessels, underneath the retinal vessels of about 1 disc diopter superior to the disc. There was no pigmentation noted, and there was subretinal fluid around the lesion and also along the nasal half of macula involving the foveal region, and also multiple small dull yellow lesions of varying size. Majority were pinpoint, was seen along the borders of subretinal fluid, suggestive of exudates, and no hemorrhages or any pigmentation were noted. Coming to left eye, her vision was 6 and 6 in left eye, color vision normal, eyelids normal, conjunctiva no congestion noted, sclera normal, cornea was clear, anterior chamber depth was of grade 4, no cells of flare, normal color, iris normal color and pattern, pupil was 2 millimeter round, brisk direct and indirect reflexes and no RAPD. Lens was clear. IOP was 20. Gonioscopy showed open angles with no peripheral anterior synecdoche. Lacrimal apparatus examination was normal and regurgitation test negative. Distant direct ophthalmoscopy showed red glow. And fundus examination, left eye media was clear. Disc oval in shape, pink in color of size, 1.8 millimeter vertically, well-defined margins, CDR of 0.3 with healthy neuroretinal rim. Vessels arising from the center of the disc, branching dichotomously, maintaining an AV ratio of 2:3. Macula normal, foveal reflex was present. This is the fundus diagrams. So, there was a right eye solitary choroidal mass with exudative retinal detachment involving both fovea and disc. So in the differential diagnosis for etiology was ocular tuberculosis, sarcoidosis, choroidal tumors like amelanotic choroidal melanoma or choroidal osteoma, then it can be choroidal metastasis, toxocariasis. So we did investigations. So in the OCT macula, we can see there is a subretinal fluid with the hyperreflective.
I think we can stop there, have a discussion on the clinical diagnosis before we proceed.
Okay.
Very well
Yeah,
presented, Dr. Sandra. You are doing very well. My first question to you is, why would you keep toxocariasis in your differential diagnosis? Why do you think it could be toxocariasis?
I put it as a last differential diagnosis because it can also present as a solitary choroidal mass, although rarely.
Yes, but in toxocariasis, you should also see vitritis and band extending vitreous bands that you typically see.
Yeah.
Would you keep toxoplasmosis in the differential diagnosis?
Yeah, toxoplasmosis, but solitary
What is
lesions.
the
In toxoplasmosis, more like chorioretinitis kind of, and multiple choroidal lesions are seen usually.
right direction? Yes, tell me. So in toxoplasmosis, you see toxoplasma, retinochoroiditis, and the full thickness of the retina is involved.
Yeah.
But there is also choroidal involvement in
Yes, ma'am.
toxoplasmosis.
Yes,
Okay,
toxoplasmosis was.
so you differentiate the two conditions. Tell me. Yes.
Yeah, it was also kept and.
Yeah, please go on, doctor.
Yeah, toxoplasmosis also can be, but it is not usually seen as a solitary lesion. Multiple choroidal lesions are small. And also retinochoroiditis
No,
is.
you see, in your state, toxoplasmosis is very common. Okay, and it can present as a solitary lesion. Sometimes the scar may not be visible because the retinitis might mask the scar and the vitritis might mask the scar initially, and you see a lot of vitritis. So in this case, how do you differentiate choroidal granuloma from retinochoroiditis? On OCT, you will see that the RPE is elevated in both conditions, in granuloma as well as retinochoroiditis. But in retinochoroiditis, the retina is also involved. And you see shadowing. You understand shadowing on OCT?
Yeah.
Okay, so when the lesion is hyperreflective, it does not allow the signal to pass through, and you see shadowing, an area of darkness just underneath the lesion. Okay, and you see a taut posterior hyaloid. Taut posterior hyaloid. You will see a hyperreflective membrane at the surface of the retina. That is a taut posterior hyaloid. That is a very important feature of toxoplasmosis, and you see vitritis, dense vitritis. Okay, which is not seen in choroidal granuloma. So here you have kept the differential, the first two, ocular tuberculosis and sarcoidosis. So if you see a solitary choroidal mass, and let's say we have ruled out choroidal tumor, how would you differentiate ocular tuberculosis from sarcoidosis clinically?
Clinically, we have to do initially tuberculin skin Mando test.
Yes,
and
very
also
good.
look for if it is symptomatic, like cultures, sputum culture, look for evidence of Mycobacterium tuberculosis?
No. Don't go to sputum culture, because latent TB, what we see in ocular TB is latent TB infection. So it is a paucibacillary disease, and you may not see active TB infection. So you may not be able to culture. You tell me only the clinical features that you see in the fundus. When you see a fundus, how would you differentiate tuberculosis from sarcoidosis? What are the eye findings?
In ocular tuberculosis, the lesions are more bright yellow lesions in TB, whereas in tubercular granulomas are more bright yellow, whereas sarcoid granulomas are dull yellow. Because tubercles are more full thickness granulomas, whereas sarcoid granulomas are usually like partial thickness granulomas. That's why that color difference. And also in sarcoidosis, there will be other periphlebitis features, and also anterior uveitis is very common, usually accompanied with granulomas. And also clinically
No, I will tell you. See how you. No. I'll tell you. See, clinically, when you see a case of choroidal granuloma, okay, so TB granulomas are generally solitary. Sarcoid granulomas are multiple. Okay, sarcoid granulomas are more commonly associated with vasculitis and cystoid macular edema. Okay. Now, in TB granuloma, because the granuloma is larger, it is a solitary large granuloma, you will often see the contact sign, where there is a surrounding subretinal fluid which will give the contact sign on OCT. And you will see outer retinal hyperreflectivity in TB granuloma. Okay. Probably TB granuloma is associated with more inflammation, and that is why you will see outer retinal hyperreflectivity in cases of TB granulomas. Okay, so and yes, so vitritis is more common in sarcoidosis. Okay, because there are multiple granulomas and vasculitis, so you see more of vitritis in sarcoid granulomas. So these are the differences that you should keep in mind. Okay, so how do you rule out choroidal tumor? How would you rule out a choroidal tumor? What test would you like to do? Systemic test? Choroidal tumor or choroidal metastasis. What test would you like to do?
Tumor markers. We will check tumor markers.
Which tumor marker?
Systemic, I don't know.
What are the common sites from which you can get choroidal metastasis?
From lungs and breast.
So what would you like to do?
We can imaging. We can do imaging, both breast imaging and lung, like CT, HRCT, chest and mammogram, to look for any lesions.
Which is the most frequent site? Lung or breast?
Breast.
Yeah. So you see, when you see a lesion and you think that it is a choroidal tumor or metastasis, you will see other signs also in the eye. Like you might, a lesion that is raised will also cause hyperophic shift. Okay.
Yeah.
And you will not see, like, vitritis is not very common. And even if you see vitritis, they are all cells, they are all tumor cells that you will be seeing. And the loss of vision is more profound in these eyes. Okay, so you have to do a PET scan. Okay, where you will see at the FDG that will localize the lesion which is multiplying, the cells which are multiplying in the body. So that is one scan that should be done, and you can so there you will be able to localize the primary tumor. Okay, because lung and breast you cannot do separate tests for both. Okay, yeah. Okay, okay, you can go on with the case and then we'll discuss again further.
So we did investigations first in OCT macula. There was subretinal fluid with the hyperreflective substances in the subretinal space. So that explains the loss of vision. It could be due to the macula involvement. And sees the review of previous reports that shows there was bilateral ovarian mass and her CA125 was elevated. So there was a suspicion of ovarian malignancy. That's why it kept a metastasis and metastasis DD. And HB of ovarian mass showed the necrotizing epithelioid granulomas. So it is more in favor of tuberculosis. And although FB stain was negative, when we from our institute we did these tests, and in that AC was normal, less than 40. Toxoplasma antibody came as negative. VDRL HIV both were non-reactive. Total leukocyte count were normal. ESR was slightly raised. TB DNA PCR showed Mycobacterium tuberculosis complex, although it was low in number, and it also ruled out rifampicin resistance.
Okay.
And chest X-ray showed no focal lesions or any bilateral hilar lymphadenopathy. So it was after investigations, we have seen that the TB DNA PCR showed Mycobacterium tubercle. So it will be a right eye solitary tuberculous choroidal granuloma with exudative retinal detachment involving fovea and disc.
Okay. Okay. Were you able to do the scan through the lesion? The OCT scan, were you able to do through the granuloma?
No, ma'am.
Okay. So we'll come back. So you have done the HRCT, you haven't done, you have only done the chest X-ray.
Chest X-ray.
And what was the Monto? Did you do the Monto test?
No, Mando test wasn't done because it was the biopsy report was showing caseating granulomas in the abdomen. She was diagnosed with an abdominal TB, and when we repeated the biopsy with again and did TB DNA PCR, it also showed Mycobacterium tubercle. So we didn't.
So I mean, was this done by the specialist, the infection disease specialist?
Yes, ma'am.
Okay, and the case was referred to you for ophthal evaluation. Is it like that?
Yes, yes.
Okay, so you are not the primary person who saw the case. The case was referred to you.
Yeah.
Okay, okay, so that's why Monto was not done. Okay. So we'll go back to the topic of differential diagnosis. So from this case, we have learned that how to differentiate between toxoplasmosis, choroidal granuloma, TB versus sarcoid, and how do you differentiate a tumor. Suppose the patient has a lymphoma. What are the features you will see on fundus examination? The patient has lymphoma.
More like chorioretinitis, like retinochoroiditis, like lesions.
No, on fundus examination, what will you see? When you look at the fundus of a patient with lymphoma, what would you see? Have you seen any patient of lymphoma? Have you seen?
Multiple choroidal lesions, multiple granuloma.
No, when we are talking about tumor, we should not talk about retinochoroiditis or granuloma. All these things are inflammatory. Okay. So what is the fundus picture you will see? You will see areas of RPE mottling, which on autofluorescence will give the appearance of leopard skin. Okay. And when you do OCT through these lesions, you will see the lumpy bumpy RPE with rounded roof configuration. Okay. The choroidal thickness will be normal in these eyes. Choroid is not very thickened. In all inflammatory diseases, whichever involve the choroid or they involve the retina or even in intermediate uveitis, if you see, the choroid is thickened. But when there is a tumor, you may not see thickening of the choroid. Okay?
Yeah.
Yes. So this is the tumor thing. Now, how do you treat this patient? What is the next step? You have made a diagnosis. What is the next step of treatment?
She was already in anti-tuberculosis treatment. So she completed her intensive phase, like continue. So she continued with the continuation phase, and we advised to consider the treatment to be prolonged. So
How
we were
prolonged? For
because
how long do you treat
uh,
these patients?
when we it was considered because when we followed up the patient, the activity around that lesion was not lessened. That's why we overfollow. When we seen that, we advised prolong the treatment, and it was prolonged for intensive phase was prolonged for 10 months.
Okay. Do you have the follow-up pictures?
Yes, ma'am.
Yeah, you can show.
This was after 2 months, and this is after 10 months after completing the
Okay.
course of treatment.
Yeah, so the response is very good. So, what is the recommended duration for anti-TB therapy for ocular tuberculosis?
Now it's 6 months, 2 months of intensive phase and 4 months of continuation phase.
See, if you read the ICMR guidelines, the duration is at least 9 months. Okay, so ocular tuberculosis you have to treat for 9 months. Okay, 4 drugs for 2 months and 2 drugs for 7 months.
Yeah.
So, what are the 4 drugs that we give for
Isoniazid, rifampicin, pyrazinamide, ethambutol in 2 months, and rifampicin and pyrazinamide. Isoniazid, rifampicin, and ethambutol in continuation phase.
Yes, so ethambutol, what is the dose where above which we should not give or above which the patient is at risk of toxicity, ocular toxicity?
More than 35 kilogram. More than 35 milligram per kilogram per day.
More than 15 milligram per kg body weight. Okay. So is it reversible when you stop ethambutol? Is the toxicity reversible?
Yes.
I didn't get you, doctor. You're saying yes or no? So in this patient,
It is reversible optic neuropathy. So we advise the patient to stop ethambutol when they.
So you have to check color vision at each visit.
Every,
Okay.
yeah, 2 months.
Yeah. And what are the other toxicities of anti-TB therapy? How do you monitor the patient?
Both along with ethambutol, also isoniazid has optic neuropathy, and the risk increases if it is along with ethambutol. And also rifabutin, although it is not used commonly, can lead to anterior uveitis.
No, what are the systemic tests you should do? When you are following up these patients, what are the systemic tests you should do? You look for toxicity in the kidney?
Yeah, RFT.
No.
Then
You
hyperuricemia.
look for toxicity in the liver. Okay. So these drugs are metabolized in the liver, and you should look for liver enzymes. Okay, SGOT, SGPT, and serum uric acid.
Hyperuricemia.
Yes. Which drug increases serum uric acid?
Pyrazinamide.
Okay. Yes, so you should be looking for these things. So am I the only one who is asking questions, or anybody else would also like to ask?
Sandra, in your history, you did mention that the patient had paradoxical worsening following the institution of ATT. So after 5 weeks of therapy, the patient's vision dropped and then slowly started improving just on ATT. How do you explain this?
So it can be, we have ruled out in this case, it can be due to Jarvis-Herxheimer reaction, which when we start ATT within 2 to 3 weeks, there will be worsening due to increase in inflammatory reaction, and thereby resulting in subretinal fluid, and like in this case, it lead to exudative retinal detachment involving macula.
So in this patient, you were fortunate that just on ATT, the patient improved and had a fairly good outcome at the end of it.
Yes.
What are the indications for doing anything else along with the ATT? When do you treat the patient?
Yeah,
What
as
else?
we are,
What do we look for? How do we treat? What are the things that you want to be careful about?
yeah, so there is a chance of paradoxical worsening. We can start steroids along with it, or when we see a worsening like this, you can start steroids. And also, when there is like in this case, there is a threatening of macula. In that conditions, we can give anti-VEGF injections, which can reduce the inflammation and can lead to improvement of symptoms. And also,
Why would you give anti-VEGF injection?
because it is it has an anti-inflammatory action, so it can.
No, you will give anti-VEGF because the TB choroidal granulomas, they are vascular granulomas. They secrete vascular endothelial growth factors. Okay, so that is why anti-VEGF injections work in these patients. Okay, compared to sarcoid granuloma, these granulomas can show vascularization. I'll ask you one basic question. Clinically, when you look at the fundus, how do you differentiate a retinitis from choroiditis? How would you differentiate?
Retinitis, it is more whitish patches, whereas choroiditis, it is
No,
yellowish.
don't tell color. Uh, don't tell the color. Okay, don't talk about color because color can be whitish, yellowish,
Yeah.
greenish. It's very difficult. No, just
In
tell the morphology. talk
In
only about the
retinitis,
shape like that, morphology.
okay, ma'am. Retinitis, it will be ill-defined margins, whereas in choroiditis, it is more well-defined. And in choroiditis, retinitis, it is superficial, whereas choroiditis, it is deep, so you can see the overlying vessels.
Very good.
Then in choroiditis,
Vitritis is more common in which one? Retinitis or choroiditis?
retinitis.
Okay, okay. So now you tell me on fluorescein angiography, what will be the appearance of a retinitis and a choroiditis?
In fluorescein angiography, the retinitis will be
Think and tell. This is a basic question. You have to tell me.
hypofluorescent, whereas choroiditis will be hyperfluorescent. Choroiditis, there will be RP involved. So, no, I think in ICGA, in retinitis, it will be hyperfluorescent. So, in choroiditis, it will be hypofluorescent.
No, you only later.
Yes, ma'am.
What happened angiography? What are we doing? What is the process? How does the dye flow through the retina and choroid? What happens?
In late phase, there will be hypofluorescence followed by hyperfluorescence in choroiditis.
Hypo and then hyper.
Hyperfluorescence in choroiditis.
That's what you're
late
saying?
phases. Yes, ma'am.
And in retinitis?
There will be hyperfluorescence.
And leakage.
Leakage.
All basics, okay. You should know fluorescein angiography very, very thoroughly, because the moment you get any posterior segment case, whether it is retina or uveitis, this will be asked. Okay, you should know everything. What is the difference between ICGA and fluorescein angiography? What is the difference?
In ICGA, choroidal vasculature. Will be hyper. In ICG, it will be more hyperfluorescent. Early hyperfluorescence will be there in choroiditis.
Sorry?
Sandra, the question is not about choroiditis versus retinitis, difference between fluorescein angiography and indocyanine angiography.
So what is the when does the indocyanine green dye fluoresce? At what wavelength? fluoresce around infrared wavelength. Okay. Doctor, can you hear me? Video
Yes, ma'am.
is yes. So these things you have to be very thorough. What is the size of the molecule? Indocyanine green and fluorescein. Why do you think the choroid is seen better in
Because
ICGA?
it passes the RP.
Hmm. Passes the RP.
Like it can penetrate the choroidal. Goes.
It does not cross the choroidal fenestration. Okay, so that is why the choroidal vessels are more clearly visualized. The choroid is more clearly visualized in ICGA.
Yeah.
Okay, so this anyway, this will like go on if we go into that. But you have to know everything about fluorescein angiography, indocyanine green, and OCT angiography. Can you tell me what is the difference between EDI OCT and swept source OCT?
Extended EDA is extended depth, so we can see more depth in choroidal. More depth visualization in more depth is possible in EDI, but in swept source, only upper layers of choroid are seen.
So in swept source, what is the wavelength? What is the wavelength that we are using? More than 1,000?
I don't know.
Yeah, so the wavelength that we are using in swept source is more than 1080. Okay, so that's how it can penetrate deeper into the choroid. And I don't remember the exact number, but in yeah, EDI, it is around 800, 800, 880, like that. Okay, so swept source will give better visualization of the choroid. Okay, even through hazy media and all, it can pass through because the longer wavelength, it can go deeper. Okay, so you concentrate on all the basics. Okay, when is your exam?
8 months.
See, if you don't, if you are not able to tell about all these uveitis, differences between TB and sarcoid and all that, it is fine. But if you don't tell fluorescein angiography and indocyanine green angiography and basics, where is the dye going? What is the arm retina time? These are the things that you learn in your uh, don't answer the questions, then it is very difficult in exam. Okay, I'm not tell you that always be thorough with your basics before you're going for exam, because generally the examiners expect you to know all the basics. High-fi questions, even if you don't answer, they are like, okay. So I don't wish to ask any more questions. So you have presented a very good case, and yeah, and you have answered a few questions well, but you have to work on your basics. Okay, doctor?
Thank you, Dr. Abhilash, for the nice discussion. Dr. Jacob?
If
Yeah,
anyone
Dr.
else
Jacob.
wants to make any comments?
No, just one last question for you, Sandra. How do you know that the lesion is subsiding or getting better? Now we have some serial photographs that have been put up there. Can you just tell us what you look for And how did you decide that now after 10 months the treatment can be stopped? What did you look for? And how do you want to follow up this patient? Can you tell us, please?
Sir, the lesion, you can see over the follow-up visits, the lesion early it was ill-defined margins, but on following up in the series photograph, you can see that it became more well-defined, and initially it was elevated. In the follow-up visits, it became more flatter. So the lesion is subsiding. That shows the lesion because it become more flatter with the borders become well-defined, and the color also it become more whiter. That may be due to choroidal and also the subretinal fluid around and the macula subretinal fluid in the macula region also subsided.
Okay. Should you follow up this patient or you're done with this patient?
No, we have to follow up the patient further so that to look for any like reappearance of or recurrence of lesions.
By recurrence, do you mean in the same place or in another place or in the other eye? What exactly do you mean?
Also, there can be lesions in the same eye, other sites, and also in other eye also it's possible because it is highly likely due to hematogenous spread. So other eye involvement is a very high possibility.
Okay, I know it's been a long day. One last question for you. What is the role of doing a choroidal biopsy? Should you ever consider that in these cases where you're not sure of the diagnosis?
It is an invasive procedure, so we would avoid it. We can look for like other its associated features and other non-invasive methods like chest X-ray, blood investigations, and also we can arrive at a diagnosis by that. And if the treatment is acting well and if the lesions are subsiding, there is no need of choroidal biopsy.
Dr. Jacob, anything more to add, Dr.
No.
Abhilasha?
Ma'am, I think, yeah. Does anyone have any other
No,
questions?
nothing, ma'am. I would just ask Dr. Sandra to be very thorough with the basics. And that's all. Otherwise, she's fine.
Yeah. Okay. I thank Dr. Sandra for coming up with a very nice case to discuss. I thank Dr. Abhilasha for the wonderful discussion, starting from all the differential diagnosis, history, basics, investigations, etc. And even we have reached up to lymphoma also. Yeah, okay. Which we used to misdiagnose in some of the cases, especially primary vitreoretinal lymphomas. Yeah, okay. I thank all the faculty of Believers Church Medical College, especially Dr. Jacob Koshi, for taking a special interest in mentoring this case and taking part in the discussion. So I thank each and every one of you on behalf of KSOS Scientific Committee for taking part in this PG case discussion. So thank you so much once again. Have a great good night. Thank you.
Thank you, everyone. Thank you.
Thank you all. Thank you.
Thank you, ma'am.